So with that, let me introduce our leadership for their reflections of this new direction. Co-chairs Andrew Dreyfus and Maureen Bisognano, and our newest member, Michael Curry. Okay, so Andrew, let's start with you. You have been with the coalition since it was just a jumble of ideas. What strikes you most about the change and evolution of this work? What's exciting you most about this new direction?
Well, first, thanks, Anna, and your team, Stephanie Chan and others, for all the great work in developing this new, for me, very energizing vision, mission, and goal statement, and for all the work you do linking the whole community here in Massachusetts and to some extent beyond our state borders to advance these issues. So thank you. You know, what strikes me is that in some ways we had to step back to step forward. And so as you described very well, Anna, we started with, I think, although they were ambitious goals, they were more modest, they were kind of contained more in the world of end-of-life care and more about advanced care planning and that kind of values, beliefs, and preferences. And that was my line. I used to say all the time, we want to make sure our care is aligned with patients' values, beliefs, and preferences. And what our research and your work and your conversation with the whole coalition membership has unearthed that's insufficient. That if we only kind of ask these questions and try to improve care at serious when people are seriously ill, it's already too late. In some ways, it's always too early until it's too late, as you've educated me on. And so I think we have to step back. And stepping back means first examining, as you said, the kind of power imbalances in the healthcare system as a whole, in the patient-caregiver relationship, the issues kind of within even families sometimes about these issues, and that we have to kind of say all care, not just care at the end of life, has to kind of be guided by this idea of that patients want their voices heard and want their agency and control, as you said. So I'm so excited about it because this is what I feel I've been working on my whole career, is to make care more responsive to the needs and views of patients. And so I'm really excited about it.
Thanks, Andrew. That's wonderful reflections. I you know, there's the sort of zoom out and zoom back, the zoom out to zoom back in, I think is like, we're going to be playing that accordion game for a while and like really adjusting that sweet spot. But I think it does feel exciting. And we struggled a lot with so much amazing guidance from all of you about how to be able to zoom out without losing, I think, the focus, which was one of the big challenges. And you all have been kind of critical in helping us kind of chart that course. And we're still going to be, you know, swimming in and bumping up against the bumpers as we try to figure it out. But I appreciate that. So Maureen, you know, you have been talking about what matters most for ages. I know in What Matters to You Day and some of the courses that you've taught, and now in sort of some of the other work IHI is doing with like age-friendly healthcare system. Like how are you seeing these linked together? What's exciting you about this kind of new direction?
Well, thanks, Anna. And like Andrew, I am really excited about this new plan. I want to begin by saying thank you to you and the whole team, because I think the process that you've gone through, looking back at the progress we've made, the places where we've made a difference, but the gaps that still exist, and then looking out, you're, I think, masterful at creating connections and looking at the assets and the resources we've got in the community, not overlooking those, but connecting to those, and then looking ahead at, particularly as Andrew said, I think expanding the vision from only having these conversations at serious illness times to really thinking about co-production of health and care. There's three things that make me most excited. The first you mentioned, and that is that some years ago, I read an article by Susan Edgman-Levitin and Michael Barry that said, we can't only ask the patient, what's the matter? We have to ask what matters to you. And I put that challenge out in Paris about 10 years ago. I said, don't just say, what's the matter? Ask what matters most. And when people went back from that meeting, within weeks, I started to get emails, pictures, videos, stories of the difference that it's made. as you said, we have an annual event, but we have a What Matters to You call every month where people from Australia to Vancouver, from Sao Paulo, Brazil, up to Sweden, get together and share stories, because it is changing when we think about everybody having that voice, not just when you're seriously ill. An example is that staff tell us that when they ask that question to people, this is global research, that about 70% of the time they find out something they never knew about the person. And 60% of the time they're changing their plan of care. It's making a huge difference. And so I love our focus on expanding from just serious illness, end of life, and really starting to think about shifting the balance of power. Also, you mentioned staff, and when we started to ask the same question to staff, especially in COVID time, when people are burned out and we don't have enough people to provide that kind of care, there was a worry about, oh, if I ask that question, I'm going to have all this new thing on my plate that I can't deal with. But what we found is that, again, research is showing that on average, when you ask the question, what people are asking for is doable and quickly solvable with just a few people. But when we ask the staff, what we're finding is that they also, in order for them to have the energy and the skills to ask, they have to be whole themselves. Yeah. And so we're finding that asking that question of staff, as an example, in the UK, turnover rates for RNs in ICUs went from 48% down to 13%, and it stayed that way all the way through COVID, because people felt cared for and tended to. The second one is my experiences with, as you mentioned, IHI's age-friendly health system. We started to look at people healthy and ill in the older parts of their lives. And IHI's team went out and did research. They found 19 models of care for the elderly population. None of them had spread. They were all very local to different parts of the country. So they brought together all of these people and said, let's create a model that makes sense and can spread quickly. Everybody needs to benefit from this. The model, as you said, now the age-friendly system has 4 M's: mentation, mobility, medication, and what matters to you. And by creating a sensible model and bringing people together in action communities, today there are 2,889 hospitals and clinics that have already implemented the 4 M's. 1.7 million patients have already benefited from it. So I think this is a big part of that system. It's really talking with all of these 1.7 million and all the rest of people about what matters most. Patients at every stage of life, early all the way through, need to have a voice. And then lastly, I'll end with a very quick story of my own, and that is that I had the great honor of being with my sister-in-law last weekend when she passed away from cancer. And she was in the hospital in Michigan and being treated very vigorously. And one day, one of the clinicians came in and said, "What matters to you?" And she said, "I want to go home." And so we brought her home. And oddly, they live in a very rural area. There are 3 big cranes that are 4 feet tall that come and look in the window every day. They come and eat food in the yard. And as she got sicker and we had her looking out the window, those cranes started to come and look in, and they stared at her, 4 feet tall. The 3 of them just looked in at her every day. On the day she died, one of her relatives came and played the harp for an hour and a half. The music was so peaceful and calming. And then her favorite singer was Bob Seger. So we played Bob Seger for an hour. And then someone turned on their cell phone and Hallelujah came on. And everybody just stopped. We listened to the whole song and she died right at the end of it. And the cranes flew away and they didn't come back for 48 hours. It was the first time ever that they didn't show up at the window. But it was such a moment to be able to share that with her And it's because someone said what matters, and we were able to take her home. So I am so delighted and reinforced by the vision that you've been building. And I'm really, really happy that we'll continue to work on this together.
Thanks, Maureen. Thanks for sharing that beautiful story. I feel like someone makes me cry at every single one of these. So you get the bingo today. So Michael, I know, hard to follow that one, but as the newest member of our group, I think, you're new, you sort of came on at the beginning of a strategic planning process, but, a lot of the things that we've talking about, I know have resonated with you along the way. Like, I guess, like what has drawn you to this work, and where do you see some of those synergies with a lot of the exciting things that are happening around the Commonwealth when it comes to improving the care for people, especially with an equity lens?
Yeah, I think first and foremost, I have to start with Maureen. And like you, and I get on these calls and I choke up and cry too often, I think, at times, because I take the stories to heart. And Maureen, you sharing that really touched me, as I'm dealing with several family members that are dealing with cancer now. And they're trying to figure out how to navigate systems, how to deal with, in some cases, the inevitability of death. And they're struggling with the conversation, who to have it with, how to have it, and even handling their affairs. And you make me think of that, Maureen, as the blessing that you shared of how you experienced that loss. It just makes me think about my own family. So I just want to say thank you, Maureen, for sharing that. That totally threw me off of what I was going to say, but I thank you for it. And it means a lot, because that's why we're here. So one is, I would echo Maureen and Andrew. Anna, you are a force. You are a force in this space. And I think, as I think about Andrew, and particularly in the last week, have been thinking about and talking about his legacy and the work that he's done in Massachusetts, and quite frankly, the ripple effect of the work that he's done across the country. It's about being a force. Can you enter conversations and be aspirational about where we need to go? We do a good job of talking about where we are, right? But we don't often set a vision on where we should be. And we think about even end-of-life care, and now serious illness care, and where we can be around empathy and dignity and respect for patients. Somebody in the room has to be able to dream, right? And that dream can be turned into a reality, but it takes a plan, a strategy. It takes a conversation. It takes collaboration, and ultimately it takes funding and support. So you didn't have to ask me more than once to do this. This was a no-brainer for me. I tend to be in spaces that I call disruptive spaces. I like when people are changing things and thinking differently about things. And when Andrew reached out to me, and I was excited to join this work. So, the things that stick out to me are, one, centering this around the patient. I have the blessing, the honor of representing 1 million patients, 52 organizations, health centers, operating out of 300 practice sites. And we serve the whole body, the whole patient, right? Their eyes, their teeth, their mental health, their substance use disorder, their overall physical health. We try to go upstream as much as we can and deal with the conditions that make people sick. And we're there at the bottom of the stream to deal with the chronic disease and the challenges they face when they enter our healthcare system. And it's overwhelming, quite frankly.
Yeah.
Overwhelming often when you think about how much there is to our system, right? It's the medications they get, it's the diagnostics and the exams that they need, it's the providers they interact with, it's the systems that they engage, it's the languages that you need to speak to them in, the cultural competence and awareness that they expect from us when they engage us. And I think the work that we're doing here, and I'm just honored, I'm known in the NAACP work, I say this to the civil rights architects that I get to sit around the table with once in a while. I said, I'm glad to be in that number, right? And then that number of folks who are being aspirational and envisioning what the system could look like when you center the patient, and you think about how do we actually treat the person to keep people healthy and to treat them when they're dealing with disease. I'm just honored to be in that group. And then last but not least, the work around equity. As Andrew's heard me say before, if not now, then when? Yeah. And if not us, then who? This is the critical moment in our history. We now realize that some people suffer longer and die too soon. and we can actually do something about it. And to say that our goal, our strategy is to treat everyone and lift everyone up to that standard of care, that expectation that everyone should have access to care is encouraging for me, right? I can be out here all the time talking aspirationally, but then I need people like Anna to reinforce that with a strategy around it. So I'm just glad to be here, Anna and Andrew and Maureen. And I'm going to roll up my sleeves. And Andrew, as you transition to other roles and opportunities, you have planted me firmly in this space, and I'm glad to be here.
Oh, thank you, Michael. And yes, I thank you. I mean, I think there's probably no more thanks that I could fit into the next hour or two for Andrew and kind of supporting me and supporting us and having Blue Cross kind of support this work from the beginning. And I guess that's sort of like next question to you, Andrew, is guys, start putting your questions if you want from the audience into the chat. I'm looking for them. It's just like when you think about these language, equity, patient-centered, like putting this as like, we have talked about this for a long time, right? A lot of these kinds of languages going around. Like, Andrew, what do you see as you're in this moment of a transition for yourself? Like, what feels different now in some of this work, and especially thinking about like a lot of the ways that Blue Cross is leading us kind of more broadly, what feels different to you now than maybe when we first started talking about this quite a lot of decades ago?
Yeah. Well, as Michael said, I mean, I think the sense of urgency and the sense that we have this opportunity, this kind of opening has been created, and we have to act now. And we have to recognize that it's going to take a while, and we're going to have to take some incremental steps. So we have to think very boldly. I was thinking about something that Maureen said. I think, unfortunately, efforts in a lot of these areas that try to make care better focus either on training clinicians or on kind of empowering and advising patients, family members. And I think what we're saying is we have to do it together. And if we kind of keep those two central groups, and I would include family caregivers in this too, because they play a really important role. If we keep them in the silos, it won't really work. It won't succeed. And it's that kind of connection that kind of can be magical connection, moment of empathy, moment of compassion between patient and caregiver, where they're both aligned. And so I was so happy because there's such urgency in the clinical community right now about issues about the emotional health of clinicians and burnout and things like that. But what Maureen explained to us is that asking these fundamental questions actually helps both, brings patient and clinician and family together in a way that does ultimately respect value, beliefs, preferences, promotes equity, promotes compassion. And so it does feel different. And I think we'll make a big mistake if we keep these two essential ingredients apart. Instead, bring them together, have them struggle together to come up with some of these big step solutions that we need.
I think that is so on the nose, Andrew. I think that like one of the reasons why that word connection is all over the place, it's like in the title of today's event, it's in the mission, is just sort of we have to sort of strengthen that muscle that connects family caregivers to clinicians, that connects clinicians to each other, that connects health systems to communities, because there's like so many wonderful pockets of sort of going on, but we don't always like spend a lot of time like building that muscle, strengthening that muscle. And those are just like, I mean, they're all just relationships, but they take nurturing and investment and structures that will support them just like anything else. So Maureen, I'm gonna ask you the next question. I'm looking, there's like so many questions coming in here, and I appreciate about that. I'm gonna try to look at the one that's up, but one I want to ask before I kind of go to the chat is part of this is a bit of a leap of faith, right? Part of us is saying, we're gonna maybe not exclusively focus on people with serious illness, because we know that might be the best way of improving the care for people with serious illness, right? So there's a dynamic tension there. It's a little sort of hard. Does that, like, how do you think about, we've talked about this in our small groups a bunch of times before. We are sort of like, it is a leap of faith to say we kind of have to take our eye off of just that seriously ill population in order to improve the care of seriously ill. What do you think are the sort of risks of taking that kind of approach? Maureen, I want to start with you.
I don't think there's any risk. I think it's absolutely vital for our better future. At IHI, we always say we need to shift the balance of power. And that is break down that hierarchy where a doctor or a nurse will tell a patient, this is your order, go home and do this, because we know that a big percentage of the time they don't do that. It's not what matters to them. So I think we really need to shift the balance of power, and the connection is critical. So is co-production, co-design and co-production. And if we don't shift that balance of power so that all the voices are together planning, I don't think we're going to get where we need to go. The other thing that you mentioned is that it's a leap of faith. In a way it is. However, every single day we're seeing science come out that says, when you co-produce care, when we work together to make the plan, like my sister-in-law Claudia made hers, it's not only better care, clinical care, better clinical outcomes, it actually produces less cost and better patient experience and outcomes. A great book by two physicians in New Jersey called Compassionomics is measuring the financial impact of kindness and compassion. And we actually, a small group of us from all over the world, also started a new website called Kindness in Healthcare. And we're doing research on the impact of that. So I think co-production and kindness are going to be critical. And as you said, Anna, we've got to get back and start beginning to give nurses and medical students the skills that they need and break down that hierarchy so that patients' voices are heard.
Yeah, I'm seeing a lot of people in chat being like, this is so exciting. It's so aspirational. How do I do this at my hospital? Like, where do I start? It's so big. And I'm going to like bounce around a little bit for all of you, because I'm going to say like some of the things that make me feel optimistic, that it isn't just sort of just totally pie in the sky, are things like, I'll give you an example, like Medicare Stars came out recently, and the CAPS measures, those are experience measures, which a lot of health plans around the entire country pay a lot of attention to. Those are really driving a lot of what's important to health plans. And those are experience measures. And a lot of the things we are talking about are really driven by communication, connection, sort of care. So I think we are seeing, if we can make those dots kind of connect across the health system, like I know health systems are like shared decision-making more broadly is a really big deal for them because it's created bigger outcomes. When we start connecting these serious illness outcomes to some of these broader things, I think we have real hope in kind of embedding them and entrenching them in ways that are going to drive things forward. This is, again, that sort of getting outside of the serious illness box. Like Andrew, you know, I know this is your sort of like last couple of months at Blue Cross, but like, what do you see in that opportunity to sort of link it with things like real levers in some of the health plan space?
Yeah, I mean, I think there's an increased understanding that consumer experience in healthcare is essential. And we know the healthcare system is fragmented, it's confusing, it's scary, it's expensive. And that until we can kind of bring those issues together and help people navigate the system, we did some separate research, as I think you know, Anna, where we went into people's kitchens and living rooms and asked them, what do you want from us, from Blue Cross? And they said, we want you to have our back when we're sick, because we want you to help us navigate the system that we simply don't understand. And we're not sure we're going to get a fair shake in it. And we want fairness and equity. And so we're redesigning a lot of our systems to try to help people when they get sick, navigate the system so they have the kind of experience that we're imagining in our kind of vision statements here. So I think health plans across the country are going to pay increasing attention to the work we're doing and similar work that really supports patients in their moments of need and families.
And Michael, I'm just thinking, community health centers are some of the hardest working, most underfunded, under-resourced places in the place that are really caring for, like so many Americans, so many, Massachusetts around residents. How do you see this sort of fitting in? Is it another thing on their plate, or is there ways to really think about how this is can make a lot of the work seem easier or more achievable? Like, how do you think about that? Because it is no one wants anything else added to their plate right now.
Yeah, I think what we're trying to do in the health center community here and writ large across the country is really think about how we can provide care better. And we know that in the health center movement, born out of really this understanding of social determinants of health, we understood that you have to treat the whole patient. we understood that you wanted to give people care that was culturally appropriate and competent for them. But I think where we also are at this time is trying to figure out if we can do things differently. And I think that's what's exciting for me from a health center leadership perspective, is as I talk to the CEOs across the state, they're thinking about how can we treat our patients differently? How can we meet them where they are? You know, one of the cries that came out of the streets in the last 2.5 years that really stuck with me, and I think it applies to what we're talking about, it was nothing about us without us. Nothing about us without us. Now that may be, you know, a racial justice cry from streets across this country, but it's about patients too, right? It's about communities too. It's about families too. And I think we're in that place where now, you know, bringing some meaning to that nothing about us without us means how can we treat them better? You know, how can we provide, as you've said, dignity, respect in the treatment that we provide for them and the services that we offer them and the coverage that we provide for them. And I think, you know, when I think about the system, I think about Andrew and his role and his successor there at Blue Cross, another good friend of mine. When I think about, we have really good people at all parts of our system right now, in the hospital systems and health plans and community health centers. And to Andrew's point, there's an alignment that I see coming across all of us that we really want to accomplish this together. So to your question, Anna, I think we're all ready for change. And I think, quite frankly, your and Andrew's leadership and Maureen's leadership is a model. And I'm going to tell you, I learned something about Massachusetts when I was young, formerly working at Blue Cross, is if we can do it here, it's going to happen in other places. So what this work is doing and can accomplish, I have no doubt, Andrew, 5 years from now, folks will be calling on you to come visit, and Anna to talk about how they can do it in Ohio and Pennsylvania and in California. So I think we should be thinking big like that.
Yeah.
That this is not just about our patients here, about our subscribers here. This is about how do we change a country in terms of how we provide care. And I think, you know, of the many things I'm involved in, some of them cause me late nights and sleepless nights. This one actually gives me joy. So I'm excited about it.
Oh, you guys are the best. I'm just looking at all the questions. We won't obviously have time to answer all of them, but some of them are just so interesting and I think can be the foundation for conversations in the future. Like things like, you know, this will resonate, Andrew, with what you were just talking about, like shared decision making is really important, but what happens when physicians don't meet quality measures or because that force or like penalize them if their patients aren't following recommendations? These are really, this is about power imbalances. This is about, do you know what I mean? Like I often think about language where we often talk about like patient compliance or adherence. And, you know, one of the questions we didn't ask in our survey last year that I always kick myself, I always thought of it later. One of these questions that's really struck with us is like, we ask a question, how often are you afraid to speak up and ask questions because you're afraid to push back and it'll impact your care? But the question I wish we asked and we didn't was, how often does your clinician tell you to do something that you know you won't be able to do? And so I think it's kind of like my sense is is that quality measurements are changing to really reflect some of these sort of like different ways of thinking and being. And I'm sure Blue Cross will be at the sort of forefront of that as like, and also because there have been problems with quality measurement. It's a pretty baby science and we're trying to evolve. I don't know if you want to expand on that anymore.
Well, no, I think we're rewriting it right now. And, you know, one of the things I'm really excited about, it's a little not off topic, but we're starting to put equity measures into what we call our value-based payment arrangements with our clinical partners. And I hope to be able to announce the first ones in the next few weeks. And I'm really excited about that because it's changing. And we've worked with the Institute of Healthcare Improvement to move about $25 million into the community to help practices think about how they do this. And some of it is foundational. They have to collect better data and they have to start asking for the data on race and ethnicity. But then it has to move up from that to ask about preferences and ask about what you need for help with your care. And that is also often going to involve bringing family members and other friends and partners into the conversation.
Yeah, I think being aspirational about what we want those quality measures to really measure is part of the collective thing we can think about together, is part of the work that I think Massachusetts has led the way in lots of ways, and a real opportunity to sort of to shape that conversation going forward. So I think it's there is a real lever for us for there to aim at and yank down as hard as we can. So we're actually about all out of time. I don't know, and we're gonna kind of move on to next. But before we say farewell to our wonderful leaders, do you guys want to say anything else before you go?
I'll just say, stay connected. We've got the potential, if we stay connected, to really shift the culture of healthcare. And I think that's the aim. As Michael said, we have to do it now.
I would just say, you showed that photograph, I think, of our first meeting of this coalition at the Kennedy Library, and we all it felt like a revival meeting.
Yeah.
And people were meeting people for the first time and making connections, and coalition's so important in linking people together. We don't want to lose that, and I hope to see everyone in person at the next one.
Hashtag spring 2023.
And I would say amen to Maureen and Andrew. Just glad that we're moving in this direction, and glad to be on the team.
Thank you guys for making the time and for all of the guidance and support. It's been invaluable. Thank you.
Thank you.